Welcome, everyone. My name is Samir Kakodkar. I'm a gastroenterologist and specialist in ulcerative colitis and Crohn's disease. Welcome to Against the Grain. Please do check out the rest of my podcasts, which can be found at the website samir3.podomatic.com. It can also be found on YouTube or Spotify by searching my first and last name. For those who are interested in contacting me regarding questions or for virtual appointments, my email is samir3@gmail.com. On Facebook, you can search Against the Grain to join the private group where there are ongoing discussions about these podcasts. There are many theories out there regarding what causes Crohn's disease. Though ultimately most physicians and scientists acknowledge that we don't know the cause, there is a small subgroup that believe Crohn's is caused by a specific bacteria called Mycobacterium Avium Paratuberculosis, which we will abbreviate as MAP. MAP mainly comes from infected cattle, but is now ubiquitous in our environment, and all of us are likely exposed to it on a regular basis. The treatment paradigm for Crohn's has mainly been the use of immunosuppressive medications which target a dysregulated immune system thought to be central to the pathophysiology of the disease. However, there are some that treat Crohn's by targeting MAP instead, with the use of antibiotics and sometimes fecal transplants and hyperbaric oxygen. There is even an anti-MAP vaccine that is in development. In my opinion, this is the biggest controversy in the field of IBD right now. In fact, the Crohn's disease guidelines published by the American College of Gastroenterology in 2018 explicitly state that anti-MAP therapy has not been shown to be effective for induction or maintenance of remission or mucosal healing in patients with Crohn's disease and should not be used as a primary therapy. This has led to subsequent letters being published in the American Journal of Gastroenterology, both criticizing and defending this statement. Today, I interviewed gastroenterologist Gaurav Agrawal and microbiologist John Aitken, who are MAP experts and will give us a comprehensive overview of this topic. As a disclaimer, I am not formally endorsing this therapy for Crohn's disease as it has not been FDA approved for this purpose in the U.S. This podcast should not be interpreted as medical advice. This is an open discussion in order to encourage more research and awareness on this topic. So thanks so much, for making time for this. And I think let's just get straight into it because there's a lot of questions people have submitted in and questions that I've had for years regarding this MAP theory. So, I'm in Chicago where it's 6 a.m., Gaurav's in England where it's about noon, and John's in New Zealand where it's about 11 p.m. So somehow we got these time zones to work. So can you briefly tell us about your backgrounds and what led you to focus your work on the research on Mycobacterium Avium Paratuberculosis? So let's start with Gaurav. Could you tell us kind of a little bit about your background?
I went to med school here in London at St. George's, and we were just studying pathology, and there were some samples of a Crohn's disease patient, a tissue sample, and they had the specimen of a ileocecal TB specimen. And so initially my interest peaked because there was quite marked similarities. So I asked the teacher, the pathologist, is anyone ever thought of an infectious cause for Crohn's, similar to this TB? And she goes, well, it's funny you say that. There's one chap in the hospital that believes so, and his name is Professor John Herman Taylor. And he really was pushing the research into mycobacterial infections in Crohn's disease since the 80s or late 70s. And so I got in touch with him, just emailed, and he then sent some papers on some treatment case series and things. And one of them was by an Australian gastroenterologist, Professor Tom Borody. And so, as you do, I got interested in that side and emailed him. And he said, yeah, sure, come over, particularly when you finish your training and things. So now I've always wanted to go to another country to learn and experience life over there. So after I finished my internship in England, I moved over to Australia. And luckily, the only hospital that gave me a job was literally 5 minutes down the road from Professor Barodi's place. So it was pretty easy to commute in the evenings or, days off to go and learn. And subsequently, I enjoyed the lifestyle so much and the teaching that I trained then as a general practitioner, because that was the easiest for overseas doctors at the time. And then I went into medical training, gastroenterology training, so I qualified as a gastroenterologist.
Wow. Okay. Excellent. And how about John? What got you into the MAP work doing MAP?
Well, I'm a medical laboratory scientist, and we had a training system at the time in which we were trained in the hospital on the laboratory benches, and we had lectures, etc. And I was in about my second year of training, and I started developing gut symptoms. And I ended up at the gastroenterology department, and I was diagnosed as Crohn's disease. And it turned out to be a misdiagnosis, but it took them 3 years to work out that I didn't have Crohn's disease. And in the meantime, it primed my mind to, whenever I would read a medical journal and there was something about Crohn's disease, I would read it with great interest, and that persisted. And I ended up in a tertiary hospital in Christchurch in New Zealand, and one of my responsibilities was the respiratory microbiology. And as part of that, we had a mycobacteriology laboratory, and so I had that as a responsibility. So in the meantime, reading up on Crohn's disease, the mycobacterial theory started to become more prominent. And then in 2005, when I was still working in the hospital system, I was asked by a colleague if I could look at his wife's sample, and that was how we found the organism in the first instance. And one of the great things about microbiology is once you see something, you can't unsee it. So it niggles away at you, and you start doing more experiments. And in about 2011, 2012, I was at a conference in Australia, and I met Prof. Brody there, and he gave me a lot of encouragement. And Will Chamberlain also took me under his wing, and that sort of led to a lot of interesting discoveries working on the organisms.
Okay. Yeah, that must have been lucky you weren't actually diagnosed with it, but certainly that makes sense how that would key you in on trying to figure out potentially what may be the cause of this. So can you explain the origins of this theory, this MAP theory, and how it came about as far as people thinking about it as a potential cause of Crohn's disease?
I think it was a case of pattern recognition. From about 1913 with Dalzell looking at Johne's disease, which is the MAP disease which occurs in ruminants, and commenting on the resemblance to Crohn's disease in humans, that started the whole thing off. It was merely that the organism that caused Johne's disease caused a problem that was very similar to Crohn's disease, and that's what happened. And then from then on, people used the molecular sequences for MAP and applied them to Crohn's disease. But the one problem and the big difference between the two diseases is that you see acid-fast bacilli present in Johne's disease, but you do not see acid-fast bacilli present in Crohn's disease. So that's a major difference. And that difference has still not been completely reconciled.
Okay. For the lay audience that's also listening, in case they're not familiar with Johne's disease, so it is a type of inflammatory bowel disease that occurs in cattle that in a lot of ways seems very similar to Crohn's disease. Would you say that's a correct characterization?
Yes, it's very similar. You get the inflammation, you get the granulomas, in both diseases, but in Johne's disease, you get the acid-fast bacilli.
Mm-hmm. So acid-fast bacilli being a specific finding you're seeing on the biopsies and on histology with special staining, and so you're seeing that in Johne's disease, but not in Crohn's. Okay, so the granuloma issue, we know Crohn's is in humans. If you see granulomas, it's likely Crohn's, unless it's a granuloma associated with crypt rupture, which can be seen in ulcerative colitis. But generally speaking, granulomas mean Crohn's. But actually, most of Crohn's doesn't have granulomas. But when you see it, it's very diagnostic in the appropriate clinical scenario. But in Johne's disease, are granulomas always seen, or is it also like a similar scenario that if you see, it's sometimes there and sometimes isn't?
I'm not a veterinary pathologist, but I think that it's, as a general rule, where there are mycobacteria, you will, if you look hard enough, you will see granulomas.
Okay.
And I would add that in intestinal tuberculosis, you'd only see granulomas in 30% of biopsies and things. So there is that variability in all mycobacterial infections of granulomas being present.
Okay. And is there a certain phenotype of Johne's disease? Is it only affecting the ileum? Is it ileocolonic? Are there certain parts of the GI tract that are common? Or is it like Crohn's, where typically it is ileocolonic, but can occur anywhere in the GI tract, including upper GI tract, even mouth or perianal disease? Is it like a similar distribution?
That's a very good question. If you talk to the veterinary people at the meatworks, 50 years ago, when cattle beasts were looked at and Johne's disease was found, it was really in the gut region, in the mesenteric nodes of the gut and those areas in the cattle. Nowadays, if the animal has got Johne's disease, the lesions will very closely mimic tuberculosis in the animal, and you will get lesions appearing in lung and liver, in distant nodes, and it is virtually impossible now for a slaughterman to distinguish between Johne's disease and tuberculosis in the animal, and so PCR is now used to identify tuberculosis in those animals. So yeah, it's evolved, I think.
Mm-hmm. Okay. So there are some subtle differences between the two, Crohn's and Johne's. My understanding is that Johne's is not just in cattle, but in also other animals, including non-human primates. Can you give us any insights or details about those specific cases?
It's just about everywhere. I mean, there was a researcher here called Graham Nugent in New Zealand, and they looked at a wide variety of native animals, predators, introduced animals, and they found Mycobacterium Avium Paratuberculosis, which is MAP. They found that in just about all of the animals they looked at. It's been found in water sources. It's pretty well ubiquitous, and it's very difficult to really distinguish the various clinical presentations in the animals. They all have fairly similar presentations.
Okay. Can you explain how MAP causes Crohn's disease? Kind of like what ultimately is the pathophysiology from exposure to manifestation of disease?
I'll do that one if you like, Gaurav.
Yeah, sure.
I think that you've got to look as though you were a pathologist in the 19th century And you've got to say, first the question is MAP present? And it's far from clear whether the organism that we are seeing is always MAP. It's a Mycobacterium species, we know that. And we know that in situ, in the large intestine and the ileum of the Crohn's patient, we know that the organism is present in those areas. We've been doing a lot of work on that recently. And we know that the organism produces mycolic acid in those areas. And we know that mycolic acid causes inflammation in the human and can trigger the formation of granulomas in the human. So if I quote Marcel Beer, who's another researcher on Crohn's at McGill in Canada, Marcel puts forward a very good theory for how individuals who are unfortunate enough to have Crohn's disease acquire the disease. And the first part is that they do have a mutation in their genome somewhere, possibly the NOD2 mutation, but for whatever reason, the white cells cannot adequately handle the organism. The human host ingests the organism, it goes into the gut. From the gut, it goes into the bloodstream, where it's carried by macrophages through the body to nodes and to through the peripheral blood and the circulatory system. It eventually finds its way back to the mesenteric nodes, and from the mesenteric nodes into the gut. So it's not a disease that starts in the gut, but it ends in the gut. And that would explain a number of things. One is that patients quite often feel unwell for about a year before they develop any gut symptoms. And also that acquisition is via macrophages that transport it around the body. I like that theory because the metabolic contents of these organisms, when they're in a dormant state, can trigger inflammation.
Okay, well, can you distinguish MAP versus Mycobacterium tuberculosis? Like, what are the major differences here? Because I've spoken about this theory to multiple physicians in the U.S., and those that have a somewhat superficial understanding of it kind of automatically dismiss it because there's this whole thing that, immunosuppression would potentially make this bacteria worse, so it doesn't make sense that our whole treatment armamentarium is immunosuppression. But I don't think they have looked into it as deeply, and there are subtle differences between these bacteria. So if you could just go over some of the important differences.
Well, again, the main thing with tuberculosis is that it is easily seen in the laboratory because it has a cell wall. So routine medical laboratories are optimized to detect Mycobacterium tuberculosis complex. And that's done by visualization, by culture, and by PCR. Medical laboratories are not optimized to find MAP. For starters, the temperature of MAP, the optimum growth temperature of MAP is 39 degrees. The optimum growth temperature of Mycobacterium tuberculosis is 37 degrees. So there's a fundamental difference even when you get to the basics. Mycobacterium tuberculosis will grow on laboratory media very easily. MAP doesn't. It requires additional factors to be able to get it to grow. So yeah, I could go on like that. The essential thing is that when you talk about MAP and TB, you may as well be talking about eggs and bacon. They're two completely different things. Mm-hmm. And the main difference that happens in the human with Mycobacterium Avium Paratuberculosis is it doesn't turn up with a cell wall. It has no cell wall. And that observation goes right back to Rod Cialdini in 1984. So they're two completely different things. And I get slightly nervous when, we all use the term as shorthand when we talk about MAP, but it may not only be MAP. but it will be a Mycobacterium species in that group. But it's not the M. tuberculosis group. M. tuberculosis.
I would add into that, so the Mycobacterium is split typically into typical Mycobacteria and atypicals, which are more, you'd say, opportunistic rather than M. tuberculosis, which is more pathogenic. And
yes.
So MAP would fall in that atypical category. There'd be longer reproductive times and growth rates, which makes particular characteristics to this group, and relating back to the pathogenicity of this, these opportunistic organisms often need an immunocompromised state to express disease. And one of the developing notions is the role of the microbiome in that side, and does that confer susceptibility? Because often, and John and I talk about this in the past, that often patients would report a trigger such as gastroenteritis or something. So whether that contributes to development of Crohn's with MAP is the thought.
Mm-hmm. So some critics of the MAP theory, and I'm going to play devil's advocate here, say that the Koch postulates have not been met for this organism. My understanding from my reading about this years ago is that they have been met from human to goat. So can you first explain what Koch postulates are to the lay public who are not familiar with that term, and if MAP actually has met these requirements to prove that an organism causes disease in humans?
Sure. Koch's postulates were developed in the 19th century by Robert Koch, and it's a very simple series of experiments. An organism is isolated from the host who has the infection, and it is grown in the laboratory. It is then introduced to a suitable laboratory animal, and after a defined period, the laboratory animal is killed, and the nodes and organs are cultured from that animal. The organism is then re-isolated in the laboratory, and classical Koch postulates are that it is then that same organism that you have isolated from the study organism is then reintroduced into another animal. So it's a way of confirming the pathogenicity of an organism. Now it gets a lot more complicated than that in the 21st century, but that's the basis. Now the study you're referring to with goats was Rod Cialdini's group with Van Krooningen, and they also did a study on monkeys as well, if I recall. And those studies I would criticise for one reason only, and that's that Cialdini's group managed to grow the organism that they associated with Crohn's disease, but it took them about 18 months, and it had a cell wall by the time they got it out. And you do not see MAP with a cell wall in a human patient. So that was a problem. They did, however, take the cell-walled organism and introduce it into animals. And in some instances, it was apparently quite spectacular. The animals developed fulminant disease, and it was argued that it was proven. The problem was they did not isolate the organism in the form that we would expect to see it in the human. That is a form without a cell wall. So that's something we're working on at the moment, and I've got every belief that we're going to be able to do something with that. Koch's postulates are a great thing, but you can't fulfil Koch's postulates for HIV or Whipple's disease. All these strange bacterial diseases. Doesn't always work, but it should work with Crohn's disease. I'm sure of it.
Mm-hmm. So if that
hasn't been done yet.
Okay. If that bacteria had a cell wall, so in whatever studies that were done, So that suggests whatever they were culturing out or isolating was not MAP then, right? So is it safe to say MAP never has a cell wall?
No. MAP has a cell wall in the ruminant, in the cow. But in the humans, when Rod Cialdini did the first work on it, they isolated the organism without a cell wall. But they grew it for 18 months until it had a cell wall. See, normally, the normal life cycle of a mycobacterium is it can go from an organism with a cell wall to an organism without a cell wall. There are evolutionary advantages in not having a cell wall. You don't alert the immune system so much as if the organism has a cell wall. So you're talking about two different stages in one life cycle: cell wall, no cell wall, and TB will do the same. TB goes through phases where it doesn't have a cell wall. But you see, the problem is that modern laboratories have to produce a profit. They have to do things very efficiently. They don't have time to do a lot of research. They're automated. The automation of the Mycobacteriology laboratory doesn't allow for detection of organisms without cell walls. So it just falls through the cracks. Nobody even looks for it.
Mm-hmm. Yeah, Barry Marshall won the Nobel Prize, right, for actually swallowing the bacteria H. pylori and fulfilling Koch's postulates to prove that was a cause of gastritis. Have you guys ever considered ingesting MAP, or is MAP already sufficiently ubiquitous that we can assume you've already been exposed?
I'd say that's right. I'd say the difficulty and fortune with Barry Marshall is that he had the treatment that could clear the bacteria, whereas we still struggle to eradicate it, and let alone put people in remission all the time. So it would be a dangerous thing to infect yourself with MAP purposefully, even though we've probably all been exposed to it already in some form.
Yeah, I can imagine you'd be pretty crazy to do anything that would willingly want to get diagnosed with this, very challenging disease to treat. So,
yeah.
Well, in fairness, Barry did get the Nobel Prize, and there's plenty of people that would like to take the risk, I guess.
Sure, yeah. I mean, don't they give a cash prize for that now? I believe it's a lot of money, right?
Yes.
So
I think
it's
about
$1 million, I think.
Million,
Yeah.
Win the prize, retire. So other critics of the MAP theory still believe it's invalid because the infection does not get worse with immunosuppression, which is what I mentioned just previously. So if we can just go back to that, because I think that's a huge sticking point for people who kind of just superficially, have a very limited understanding of this theory. And so they mention, and this was even mentioned in the recent editorial letter that was published in the Red Journal as a response to your guys' group about the MAP being excluded from the ACG guidelines for treatment of Crohn's. So they said that as Mycobacterium tuberculosis often gets worse with immunosuppression, as well as Mycobacterium avium intracellularly in the intestines of HIV patients. So can you explain just once and for all why this shouldn't be an issue, and why MAP is different? I mean, I know you kind of went over that just now, but specifically within the context of immunosuppression, why is that bacteria not necessarily getting worse with the current treatments we have, the immunosuppressive treatments we have for Crohn's?
John, do you want me to go first, and then you can?
Yeah, you go first, and then I'll put my perspective in.
So, the important thing is, you said it. There is a limited understanding of this, and they're applying a general principle to specific characteristics. So it's not like a one size fits all. But in part, as we were saying, MAP is part of a different group of mycobacteria, slower growth rates and more opportunistic. So immune suppression won't necessarily reflect what we see in Mycobacterium tuberculosis, where then it erupts and causes disseminated disease. Whereas MAP because of its low growth rate, and would more likely revert to dormant forms, as John has mentioned. And so this ability to transform into different forms is beneficial to the bacteria to persist in your system. And, it's not like you'd say all immunosuppressant, we use steroids for cerebral tuberculosis and, steroids for Mycobacterium or MAC infections in the lungs. And then there's also been some case series and case reports of using etanercept and anti-TNFs for Mycobacterium leprae for their painful neuropathy that's not responding. So you can use immune suppression alongside. And I think, in fact, one of the big things will be combination therapies, particularly for aggressive disease, where you're trying to get control of inflammation with, say, biologics or anti-TNFs, and then use the anti-MAP antibiotics alongside. And I believe there's a little subsection in the Red Hill trial that has a group of patients as such that showed even better responses. But I'm sure we'll come to that later on.
Mm-hmm. So,
yeah, I think TB is an infection. It's a pathogenic organism that is capable of replicating easily and destroying tissue and setting up a caseating lesion in the patient. MAP doesn't behave like that. The nearest I would say, based on what we are currently seeing with tissues, is that it's like a foreign body reaction. The organism sits there leaching out metabolites, and those metabolites cause inflammation. So it's logical that steroids will reduce the inflammation but not kill the organism. Biologicals will reduce the cytokine and TNF productions, but the organism is not causing an infection. If it was causing an infection, the anatomical pathologist would be able to see it in situ doing so. And what we're seeing so far is that it's more there as a foreign body reaction rather than as an infection. So the two organisms, one is causing an infection in the case of tuberculosis, the other is causing inflammation in the case of Crohn's disease.
Mm-hmm. No, that makes sense. Why these medicines may be potentially helpful to decrease that immune response to a potential kind of like foreign body reaction. But I have read some of the work from your group stating that some of the medicines that are used for Crohn's potentially have an anti-MAP, almost like an antibiotic effect, in addition to tampering down the immune system. Specifically, I know 5-ASA, azathioprine, anti-TNFs, but I'm curious to know what your general comments on that are now, how that works. And also, what about the other medicines like methotrexate, vedolizumab, ustekinumab, these newer ones that also work for Crohn's, and what potentially how those would be helpful for a MAP infection?
Well, we've looked at Remicade, and so I think is Professor Nass's group in Florida, and we've seen in the test tube we have seen an antibacterial effect, in that it has stopped replication. When we look at patients who are on Remicade, we see a markedly different appearance in the cell wall deficient forms that we see there than we do in patients who are on some other anti-inflammatory type treatments. So the biologicals, certainly Remicade does produce a bacteriostatic effect, but it also is very good at damping down inflammation at the same time. Whether the stasis is a side effect or is beneficial or not in the patient, I don't really know. But when you start looking at these things in detail, like if you look at some of the more simple ones that are derived from the sulfur drugs, they will have bacteriostatic effects as well. And I think the thing that we see is that when a patient who is on any therapy from a gastroenterologist and is in remission or is not in a flare-up will have very few of the organisms that we associate with Crohn's disease. A patient who is in a flare-up will have a lot of the organisms. So we see in the laboratory a relationship between the patient condition and the therapy, if the therapy is working, no matter what it is. So it's not, you can't sort of say it's entirely related to infection versus foreign body, because of course when you use anti-MAP in a patient, you will slow the metabolism of the organism eventually. It's just that the organism is not actively replicating, so it takes a while for the antibiotics to get through. But from the point of view of a patient, it's academic as long as the patient is in remission.
It's interesting you mentioned sulfa, any medicines that have a sulfa component to it. We know sulfasalazine, compared to mesalamine without that sulfa moiety there, has a little bit better data for inducing remission in Crohn's colitis, mild Crohn's colitis, compared to just 5-ASA alone, although some people don't put much credence into that data. But that would mechanistically make sense from what you're saying, is that potentially that sulfa component of it may have some sort of additional anti-MAP activity. But I was just wondering, do you guys have any comments on the other meds? I know with anti-TNF, what I've read is that MAP-infected cells express more membrane-bound TNF, and potentially anti-TNF is binding to that and leading to apoptosis of these MAP-infected cells, which is why that may work. But what about these other, do we even know how vedolizumab or ustekinumab may influence this infection, or what it may be doing?
I don't think we know the newer ones, vedolizumab or ustekinumab yet, though John might have some research into that. The other ones, like you said, methotrexate or azathioprine, was predominantly studied by Robert Greenstein in the US and showed some antibacterial actions of that directly onto MAP. The TNF side, that study, particularly by Horatio Buck, showed that it reduced Mycobacteria or MAP titers, but that was in blood samples rather than in vitro. So I don't know what John has more there to add.
Well, yeah, I think the problem is that the autoimmune inflammatory side of Crohn's disease has enjoyed an incredible amount of funding, research, interest from pharmaceutical companies. So there is a lot known about how these organisms work on the immune system. But there is very little known about how they work on infections or on bacteria, because bacteria are not considered to be part of the autoimmune syndrome. If you took it the other way, and if suddenly overnight everybody started to do research on an infectious trigger for Crohn's disease, you would be in a position to be able to answer some of these questions, and I think it's fair to say that will happen. I think we're now producing enough evidence to really be able to start getting people to focus on the question of biologicals versus antibiotics in this situation. And it may well be that both work in terms of complementary medicine. And also the one thing I will add is that the patients themselves, when you talk to them, are using a plethora of alternative compounds and therapies that they're getting from naturopaths, and they are also added to the brew in the human host. So what on earth is going on in there? I don't think we really know, because of self-medication.
Mm-hmm. Right. Yeah, and we'll get into that a little bit later, specifically with diet. Diet is a main thing that people
massive,
change, and but I have some more detailed questions about that later. Another criticism in this from your detractors, your skeptics, is why wouldn't veterinarians or farmers have more Crohn's disease, as they're probably more exposed to this bacteria, and we generally see more Crohn's in cities rather than in rural areas. Poor hygiene seems to protect against IBD when it should otherwise facilitate the transmission of MAP. And so what is the explanation for that phenomenon?
Do you want me to go, Gora?
Yeah, go for it, John.
Okay, I think the Crohn's is a complex interaction between the host and bacteria, and it includes the immune system and probable mutations in the immune system, depending on whether there is a mutating gene and it's heterozygous or homozygous. That would influence somewhat the susceptibility of the host, but a patient can walk around with those mutations and they're fine until they come into contact with the organism. So you're not looking at a situation where MAP is out there actively infecting everyone. MAP is out there infecting a proportion of the population that are susceptible to it, and over the whole community, that ratio is going to be about the same. You're going to get about the same number of people working on a cattle ranch as there are working in PricewaterhouseCoopers or somewhere like that. The ratio of susceptible hosts is pretty much the same across the population. So they only have to come into contact with the organism. And that perhaps explains why we are seeing these large increases in Crohn's disease, because the organism is more ubiquitous than it was in the 1950s.
Leading on to that, we just said that immune susceptibility. As we know, in urbanization, you get more poorer health statuses, pollution, overcrowding, diet, as we say, and then there's some people that believe continued exposure to MAP, particularly in early life, so in farmers or veterinarians, that you get something called like immune priming, so you're optimizing, consistently stimulating your immune system to fight off or prevent MAP developing pathogenicity.
Studies have shown there is a higher proportion of Crohn's disease with MAP than in healthy controls. About a 7-to-1 odds that you actually find MAP. So what about the cases of Crohn's disease without MAP? Is that just a testing issue where we're just missing it in those patients, or is that a different phenomenon, a different pathophysiology that we're still calling Crohn's?
I think John's going to answer this quite well. I'll just say quickly that I think it's because they're using PCR molecular methods, which is pretty non-specific for MAP and Mycobacteria in general, and particularly using PCR itself, the process has to be quite precise and in experienced hands, so that's why we're getting different results from different studies. But yeah, John will carry on, I suspect here.
Yeah, I think the main problem with the inverted commas diagnosis of MAP in research areas and laboratories is that it's based on PCR, and it's particularly based on a process called nested PCR. So you PCR the sample, and then you PCR the PCR product. So it's sort of like looking for grains of sand in the end, and you'll get positives and you'll get negatives. Now, if I talk to a gastroenterologist and ask him what he wants in a diagnostic test, he wants to know whether the patient has it or not. And when some of these studies show that up to 40% of normal human controls are positive for MAP, I don't think we have a diagnostic test if we use PCR at this point. We need to, and others have said exactly the same thing. We need to grow the organism, and we need to be able to see the organism. And I'd say that we're actually in a position of having done that in our laboratory. We get to other diagnostic laboratories, but PCR by itself is not of use to a clinician, and I think that's one of the big problems about the MAP theory. People don't diagnose it.
And that's where, understanding the behavior and characteristics of mycobacteria is really critical. It's not just simply, as we're saying, you get the infection, you develop disease. It's not a cause and effect. There's, you could be colonized with it, and so many people will be.
Mm-hmm.
You definitely get transient colonization. It's not like TB, where if you've got TB, you really have an extremely high chance of having the disease, or have had the disease. You can have Mycobacterium avium or Mycobacterium intracellulare, which are also members of the same group that MAP is in. You can get those transiently colonizing you from water or from shower heads. It's a difference between what Gorev described as the atypical mycobacteria or the opportunistic mycobacteria and the pathogenic mycobacteria. Yeah. I've no doubt whatsoever that as you said before, that the majority of the human population in the Western world will have come into contact with MAP probably on a monthly basis.
Mm. Okay, so we've established that PCR is not a very accurate method to determine if this is a problem if you particularly have Crohn's. But what about the other tests like culture-based flow cytometry? I guess a lot of people have submitted, like, how do we get tested for MAP? Is there a way that is commercially available for people, particularly in the U.S. or worldwide, where they can get tested? I've actually seen patients in my practice who have told me that they got tested somehow, and at the time I didn't dig too deeply into how specifically that was done. I don't know if that was from PCR, but and one patient comes to mind. She told me, it was like very positive, and as a result, she was on MAP treatment for a long time. So what are the options for people to get tested?
Well, there's a number of commercial laboratories who do genome testing of the gut microbiome, and if you follow the reasoning that MAP is present in food and the environment, then if you PCR hard enough, you will find it in stools. So it doesn't really relate to whether the patient has the disease or not if you test the stool. That's one problem. Mm-hmm. The second problem is that you don't really have to go to the stage of doing PCR and doing complex procedures. In the US, the main thing that I would advocate you have to do is follow the specific protocols put out by the American Society of Microbiology for the detection of Mycobacterium species, and you'll find it. It's not as though it is difficult to find. It is just that laboratories use methods that are optimized for tuberculosis. If you go outside your level of comfort and use the methods recommended by your professional body, then you will see it.
Mm-hmm. It seems like if it is a ubiquitous bacteria and a lot of people are getting exposed to it like on a monthly basis, I feel like testing at this stage may not be that clinically helpful, because even if most people, if you look hard enough, are going to have it, right? Would you say even if they don't have Crohn's disease, there's a relatively higher probability you're going to find it anyway? So
yeah,
I don't think it's so. Would you say? We'll get into more treatment questions later on, but with the way you guys are treating Crohn's, are you pretty much assuming Crohn's is caused by MAP in most of the patients you're seeing, and just assuming it rather than using any kind of diagnostic tests to see if it's there?
I would say that's true. Just taken it firsthand that, if they've got active disease and they've got active expression of MAP occurring, we have been handicapped, and that's always been the case, of a diagnostic test that's reliable, quick, and that's where culture-based methods have to be the gold standard, because with that you can observe the organism, what form is it in its life cycle, and if it's like rupturing or other features, then we can treat more effectively. And that's what we do with malaria, isn't it? You do the wet films and things. So PCR really seems to have taken over diagnostic because of ease of use, and again, using general principles to every situation, which is not recommended, I would say. But yes, so I would say we are treating our Crohn's patients assuming they've got active forms of MAP because of the disease expression.
Okay. Is there a... Oh, go ahead.
I was just going to add that in the laboratory, you can't really assume something is either there or it isn't there, provided you use techniques that can grow it and can visualize it. It's when you start using PCR randomly, and if you look at most of the studies that have been done, they're based on PCR, and they're based on a particular sequence that is associated with MAP. But we're now doing a project with anatomical pathology, looking at deep ileal tissue for the organism, and we're seeing it. Mm-hmm. So, and we're not seeing it in controls. So that's something that Robert Koch would have done. But somehow or other, the last 100 years seem to have floated by, and we're still not taking those lessons that are so essential to diagnosis of infectious disease. Look for the organism and culture it.
And as they say, nothing worth having comes easy or simple, So it may take a bit more time to culture it, but you'll get so much more information. By observing the organism, we can understand it, which you can't do with PCR.
Have they found, or is there a particular phenotype of Crohn's that is more likely to be related to MAP, like ileal Crohn's, or are you saying that pretty much all Crohn's likely is due to MAP?
I would say. Oh, sorry, John, go for it.
No, you go.
I would say there is pretty high percentage is related to MAP infections, and as John was saying, mycobacterial in general. It's whether you get the stricturing disease or fistulizing diseases in Crohn's, whether that's different involvement of the gut flora or different metabolic pathways of MAP expressing. That's really I think more needed to be investigated, but I would say we still think MAP causes both phenotypes and even other features.
Mm-hmm. I'd put it a slightly different way. I would say that the atypical mycobacteria are capable of causing inflammatory disease in susceptible patients. So I'd move away completely from locking it into Crohn's disease, because Crohn's disease it's got a lot of grey areas in it as a clinical diagnosis, and say that that these cell wall deficient or organisms without cell walls, mycobacteria without cell walls, do have capability to cause inflammation in human hosts.
What about ulcerative colitis? Does MAP play into ulcerative colitis at all, or do you consider them this to have a separate pathophysiology that's completely different?
That's quite interesting, that question, and even my colleague who treats for MAP thinks it's another infection involved. I suspect there is some involvement of MAP utilizing different types of white cells, for example, neutrophils, but there is a greater contribution from the gut flora, and that's why it's more of a superficial infection in terms of the lining rather than a deep infection of the tissue like Crohn's. But we do know, you can transform from colitis to Crohn's and vice versa, and you do have that grey area of undetermined colitis. So I do suspect there is an involvement of MAP there, but it's been less studied than obviously for Crohn's.
Okay.
And I agree that is a really good question, and I've thought a lot about it. And from the laboratory point of view, the answer can be found by isolating the organism from the tissue of patients with definite ulcerative colitis and putting it into an animal model, and ditto with Crohn's disease, because that's going to provide you with the answer. If you have organisms that are in deep tissue in the colon and are associated with inflammation and or granulomas, and you then put them into a laboratory animal and you get a similar picture, then I think you have to think about the possibility that both diseases are associated with it. If it doesn't happen in ulcerative colitis, then you can cross ulcerative colitis off the list.
Yeah, I agree with that. But there were those set of studies where, they did diversion therapy of the fecal stream, and, high number, I think it was 60% or something of the colitis went into deep remission, and then they reattached the root and, subsequently they relapsed. So there does seem to be an involvement of the fecal stream or contents of the bowel in association with colitis.
Mm-hmm. Just the distribution of the disease in Crohn's disease, where you kind of have these skip lesions, and it's to me, just from a superficial perspective, seems more believable that would be an infection or even like a foreign body type reaction that you mentioned. But ulcerative colitis being this diffuse inflammation starting from the rectum going proximally suggests more of like an autoimmune phenomenon, or may not be infectious in nature. But that's not based on anything, just a thought I had. So okay.
I think there's a continuum. I think one must lead into the other somehow.
Sure.
Two close together and the symptoms are very similar.
Sure, and it's so often found that people who initially had a diagnosis of ulcerative colitis end up getting surgery, and then later on are determined that they likely had Crohn's. Even the pathology specimen on the colectomy, the pathologist will say, "Oh, this is ulcerative colitis." Then 5-10 years down the line, then they have small bowel involvement or something, and then you change the diagnosis. Yep. So it's a lot of overlap here.
So let's not forget. Sorry, just one last point is that autoimmune phenomenon can be triggered by bacteria and infections as such. As we see with rheumatic fever and endocarditis. So quite possibly there is a sort of a term autoimmune plus immune reaction that's causing disease.
Mm-hmm. Does MAP cause any other diseases? Like, what about somebody on one of my Facebook groups had a specific question about IBS, irritable bowel syndrome? Makes sense to me how perhaps that could be kind of like a subclinical thing. There is some controversy. Is IBS like on the spectrum of IBD? Is it like a pre-IBD disease, and only a subset of those with IBS subsequently develop IBD, overt inflammation? So could MAP be involved with that?
Yeah, and we also, association with IBS with IBD, and particularly stricturing Crohn's. And very good. It's a bit controversial, but likely I would say IBS is like a pre-Crohn's. Particularly, you see the terminal ileitis, and what does that represent? And you get the lymphoid follicle, so there is some immune reactions occurring. And broadly, and John will again talk more about these other forms, but there's postulations and propositions of like psoriasis or sarcoidosis being caused by MAP, and maybe that depends on the different type of macrophages that in those systems that triggers those immune pathogenicities.
Yeah, I think from my point of view, when Prof. Brady talked me into looking at these things, I specifically limited myself to Crohn's, because when I first started looking at it, I got probably the people from your Facebook group, were onto me to, well, I've got sarcoidosis. I want you to look at a sample for that, and rheumatoid arthritis was another one that cropped up fairly commonly. but we stuck to, for a long period of time, we stuck to just Crohn's disease because I figured that if we could work out a pathogenic mechanism for the most outstanding example of an autoimmune disease, then the others may or may not fit into that pattern. But we needed to have culture and identification worked out before we went into it. And now we're starting to look at it. I've been hooked into a trial in Australia in sarcoidosis, and we've looked at a few rheumatoid arthritis patients, and they're interesting. But, you know, microbiology is pattern recognition. You've got to look at a lot of samples before you start to draw a conclusion. But Crohn's disease I'm happy about. It is possible, nature being very economical with its strategies, that these things are occurring in these other autoimmune diseases to a greater or lesser extent.
Mm-hmm. It's interesting. I'd say that we had 2 cardiac sarcoids respond to the anti-MAP. They were end-stage patients who just, seeking treatment and had Mycobacteria proven, as you said, from some source. So there is some possibility, and does show a lot of features of atypical mycobacterial infections of the lung. So I think we're sticking to the most common and most proposed condition, and then we'll work from there to what others, because we know TB can cause different diseases, manifestations, lung, gut, you get cerebral TB and Pott's disease, so possibly.
Okay. So are there regional differences in the type of MAP? So, what is the significance of this? Like MAP, for example, I read there's a specific type called Indian bison type, or, different like subtypes of that particular bacteria. Does that have any clinical consequence?
The bison strain frightens me. Because the characteristic of the MAP bison strain that is transferring across to the herdsman in India has a cell wall, and MAP in the Western world, or Mycobacterium Avium complex in the Western world, hasn't quite achieved that same trick in Crohn's disease. It doesn't have a cell wall. If it's transferring in India with the cell wall, then the question I would really like to know is, do those individuals have a genetic susceptibility or not? If they don't have, in other words, if it is spreading across these people without differentiation according to the genetic makeup, then we have a big problem. And then I start thinking maybe what is going on in the patients that we are seeing with Crohn's disease is that the cattle strain is trying to do the same thing that the bison strain has already achieved. And zoonoses are a hot subject right now.
I was going to add, the strain diversity is one of the most concerning things from my point of view. And being a zoonotic infection, the human is not the natural host. So how we respond to that foreign pathogen is quite a concern. If there's a more virulent strain, which I suspect we are seeing, greater burdens because of the rising rates in pediatric IBD, which is again a different phenotype, seemingly more aggressive and responding more to diet-based therapies. So I'm sure there will be more severe strains out there that's occurring.
So, go ahead.
So it's clearly a zoonotic disease because MAP transfers from cattle to deer to sheep. We just happen to be the species that's been spared up until now.
So how does someone get exposed? How does a human get exposed to MAP? We talked about it being in cattle. Is it safe for example, a vegan to assume they're doing the right thing by not eating beef or dairy? My understanding is that it's pretty much everywhere now. It's even in the water supply. So, what are the specific sources of getting MAP for most people?
I would say, go for it, John.
I think food is the most likely, oral transmission's the most likely route. It's going to be in water. It's going to be in food and milk. There's Irene Grant's group that are interesting work on pasteurized milk and isolated viable MAP from that. So it's going to be pretty much right around the town now.
Been found in again, breast milk. It can, so the critical thing, it can survive current pasteurization. So, I always say to my patients, avoid beef particularly, and drink, if you're going to have milk, use ultra-heated treated milk. Yeah. Even then, that's not completely, I'd say 100% safe. So it's probably everywhere. And in the water supply, look, it exists in amoeba, and that's why, it can survive in water supplies and it's transferred, so groundwater. And that's one of the reasons we see high rates of Crohn's around high rates of Johne's disease. So how they're shedding it, and it's not only human consumption of local products, it's probably environmental transmission.
Yeah. I think foodborne would be the most probable cause of transmission.
Okay, and it doesn't seem like really any type of dietary pattern is safe, because I've seen many patients who like vegetarians who are diagnosed with Crohn's.
That's it. Yeah.
Particularly Indian patients from South India. I see many of them, and but they don't eat the beef, but oftentimes they do eat dairy, and then the water supply, and then all bets are off. I mean, everyone has to drink water. Yeah. So
that's right.
Yeah. Okay, so how is there a strategy where we could eliminate MAP from the environment? Is there a realistic thing that could be done if enough money and enough focus enough of a spotlight is put on this problem?
Well, the UK government mandated a higher pasteurisation temperature for milk on the precautionary principle. And so if you target the food chain and make sure that the food chain is free of it, then you're going to be fine, I think. That would be the main factor. But to try and get rid of it from the environment now, I mean, in our country, I think it would be impossible.
There's that confliction again. We're testing for MAP in Johne's, or for Johne's cattle, because it cross-reacts with bovine tuberculosis tests. And so if, I don't know in other countries, but if they're positive for bovine tuberculosis, the farmer has to cull the whole herd, which is obviously economically damaging. So they're not doing mandatory testing for Johne's. So that John was saying, to eliminate it from the food chain is the only real way, but then also with vaccination of animals and livestock would be the other one as well.
I remember seeing a study done in New Zealand on the economic burden of MAP in agriculture, and it worked out about 7 kg per carcass difference between a MAP-infected animal and a non-infected one, which is an economic return on the investment of growing the animals. So there are a number of arguments for eradicating it, but at the moment I don't know how many countries in the world have it as a notifiable disease in animals.
Mm-hmm. Yeah, that's right. Should be.
It seems to be a very prevalent infection in U.S. dairy herds. I read that over 90% of dairy herds you can find it as of 2007, and that number had been increasing. So I wonder what that is now. But it's go ahead.
It's the old model that is used for infectious disease, which is if you pick up your fishing rod and go down to the lake and there's not many fish in it, then the odds of catching a fish are very low. But if you go down to the lake and there's a lot of fish in it, you've got a really good chance of catching a fish. And what we're seeing in agriculture is these large food lots. And in New Zealand, we see them in large dairy lots. So we have 600 animals or 1,000 animals together on a dairy farm on occasion. And so that if one animal in that group gets MAP, then it will quickly spread throughout the rest of the herd. So we have problems of population size and density, and that is accelerating the spread.
Mm-hmm. Do you think the bacterial load matters once you have Crohn's, once you have presumably an established MAP infection, as far as these recommendations like stopping eating beef or milk that isn't ultra pasteurized or presumably free of MAP? Do you think that makes a difference, or is it like once this process starts, it's pretty much over? I mean, it's not going to make a difference.
No, I think it does make a difference.
Yeah.
We see patients who are in flare-up, and they've got a lot of the organisms. We see patients who are cruising along in semi-remission or remission, and they have very few of the organisms. Now, the one thing that we don't know is this organism, once it's in your body, is it slowly getting hit by the immune system so you're decreasing the numbers, or is it just sitting there slowly metabolizing and occasionally growing? Because if it's a situation where the body is taking a few of them out every day, then getting into remission is probably something, if a patient can achieve remission, that diet, etc., becomes very important, I think. You do not want to refuel yourself with these organisms.
And we also talk, John and I, that you want to try and prevent reinfections or different strain being acquired. That makes the disease more difficult. So,
if you don't,
but patients are really conscious of that. They're very conscious of the need to moderate the diet in some way, shape, or form, but we don't really know how to do it.
Well, do you guys avoid dairy and beef because of what you know about MAP? Taking precautions.
I have ultra-heated treated milk, UHT milk. I would have cheese time to time, but and I don't eat beef or red meat particularly, so that's not a problem.
And I am the positive control in that experiment, because I just go on as though nothing had happened. I freely partake of everything, but on the assumption that I'm now 69. So if it was going to happen, not wishing to tempt fate, but if it was going to happen, it would have happened by now.
Yeah. Okay.
But if I had any sign of any susceptibility to an autoimmune disease, I'd take it very seriously.
Okay. So let's get into the treatment now. So how do you decide which antibiotics to use? And I'm sure your protocols have evolved over time, but as far as currently right now, what is the standard treatment for somebody with Crohn's who comes to you?
So the treatment of Crohn's was developed with Professor Herman Taylor and then evolved, I'd say, with Professor Borody. And it's been basically on treatment of leprosy or Mycobacterium leprae, because that seems to share the most common features and genetics with MAP. And typically, principles of mycobacterial infections, and which is one of the problems I think has led to all these trials and things, is that you need at least 3 to 4 antibiotics to target it in different ways. And so typically the core ones is erythromycin, which is either rifampicin or rifabutin, and even between the two there are quite big differences in terms of half-life, with quite significant lengths, with rifabutin being the second generation. And then you'd have macrolide, particularly like clarithromycin, the most common. And then the third component is clofazimine, which has been around for decades using for leprosy, and it works in specific mechanisms for mycobacteria, which were only recently understood and discovered in the last 10, 15 years. Then we use a fourth antibiotic, and that depends particularly on presentation of clinical disease. So if you've got fistulae, we would often, and I think we generally now go with this combination of metronidazole, which John and I know have seen that it targets particularly the persister forms, or anaerobic or the cell wall deficient forms. So typically 4 antibiotics at least, I would say.
Okay. What other factors influence the choice of that fourth antibiotic? Because I read in one of your publications, it's not just presence of fistula, but site of disease, also prior therapy, other diseases they may have. What are the variables that determine that last fourth antibiotic?
Yeah, the main couple, I guess, would be response. So if they've tried something before and they haven't responded, so then we would use something similar, maybe like ciprofloxacin, and then allergies to antibiotics as well. So that would determine that fourth one. But I think the best ones we've seen are metronidazole, something from the nitroimidazole family, like tinidazole, which we're currently using more because there seems to be less side effects from that and long-term damage. Because obviously the concern with metronidazole is neuropathy, after a period of time. So, but with tinidazole, which is used more for other parasitic infections, it doesn't seem to have that problem.
Okay. And then this is kind of like a step-up approach to dosing over several weeks, right? You start at low doses and go up from there?
Yes, so that again is based on leprosy treatment over the years, the experience there. So the reason for that and the rationale for this ramping up dose, as we say, is that your liver test or your liver function doesn't seem to react as bad as giving full dose straight away. We're not too sure why that happens when you give a full dose, but it seems the body does gets used to the drugs with the incremental steps, and so rifabutin is the main drug that we're concerned about, that we do the ramping up dose, so that's why.
Okay. And if there are clinicians, I mean, there's not many that I know of in the U.S. that do this, but if there is a clinician that wants to implement this, is there some sort of guide available, or any guidance you can give as far as wanting to actually implement this? I mean, personally, this is something that I want to offer patients because, and I'm still in my mind trying to think where this would fit in my current kind of flow as far as what I try first. I know and we're going to go over some of your data that shows that you had a case series of patients who did really well when this was like the first treatment they tried. But I think definitely it's something that should be in your toolbox, and something that could be tried, as opposed to referring somebody to a clinical trial. This may be something that I would try before potentially doing something like that. Because anytime you do that, you risk the patient getting a placebo in a clinical trial, and I'd rather do something that at least has some data already behind it. But what should a clinician do who, we don't necessarily have your experience with using these antibiotics? Is that something advisable, or how does that even work?
Yeah, so we do have, we used to treat a lot of patients worldwide, but that's before the demand got a bit too much, particularly the local population. But often we would assist the treatment with a patient who has a gastroenterologist or even a family physician on board who can monitor and treat alongside and prescribe the medication. The trouble, with this has been sometimes the availability of medications, so like clofazimine is not available in the States, so they'd have to import it either from Australia or from some other country. But when we work with the doctor, we give them letters. We often offer online Skype consults every 3 to 6 months, depending on their progress, and we're always available even just for general guidance or questions. And there is a protocol that we have that people can follow, and it's got the steps of how to implement the therapy, how to commence it, and what to look out for, when to do your blood tests, common side effects, rare side effects. So there's quite a good explanatory guide to it.
Okay. Great. Yeah, maybe afterwards I can email you to get that guide. But yeah, I'm happy to work with you guys, or any way that we could get this treatment to patients that it may benefit. So
for me, it's one of the most tragic things that it's not even offered as a last resort therapy, and patients are going to surgery without it, and there is pretty good responses with it. And traditionally, the clinic we're working at is that we'd see the end stage Crohn's patients who are desperate, don't want to get surgery, so they come and find us.
Right.
And they've tried everything, and I'd say 70% response, 60-70% just as a figure with that. And so it should definitely be offered even as a last line or second, third step, if not my preference is first step, but I can understand that may take a bit of time.
Mm-hmm. Okay, you mentioned the liver enzymes as a potential side effect of antibiotics. What about other things with long-term use of these antibiotics? And for the general audience that's listening to this, the treatment course for this, for most people, is going to be lifelong, right? From what I read, a lot of people relapse when they get off the antibiotics. And
this is true. This has been a difficulty we've had without a diagnostic culture, because we don't know, has the organism been eradicated? Is it just put into dormant forms? How long do those dormant forms take to reactivate, and what does that? So typically, at least we say at the moment, treatment is about 18 months to 2 years, and that's leprosy treatment's 18 months to 1 year, and TB therapy is 6 to 9 months now, and that corresponds, it seems, with the growth rates of the bacteria. So the longer it takes to grow, the longer therapy you need to get it into the dormant forms. Lifelong, there are patients who have been on this treatment for 12, 15 years, but often we would say, to reduce it to a maintenance dose, which is literally half dose, and hopefully 3 instead of 4 antibiotics. And these patients who have gone on it for this number of years don't want to come off it, even though we try and encourage that because they feel so well. I know one patient is living in one of the islands in Indonesia, in Australia. He's an Australian, and because he's quite remote, he didn't want to come off the antibiotics for fear of relapse. And as you say, it can take months or years for that relapse to occur, but the vast majority would experiencing it. So in terms of trying to prevent a relapse and why can't we eradicate it, once we understand it, we would develop better combination therapies that would hopefully eradicate it. And one of the trials that we've been doing is using FMT or fecal transplant after the course of the antibiotics, and the long-term remission paper was based predominantly on that approach, and so that's now our target. So we give them the antibiotic treatment, then fecal transplants, and even that in itself is being refined in techniques and trying to get better implantation. Long term will be something either dietary or vaccination to prevent a relapse. That's probably the way it goes.
And how many fecal transplants are you guys doing after the antibiotic course? Is that repeated ones or just one?
We typically give 3. And then we see how they are. So literally, it's a course of 3 fecal transplants over a few weeks.
Okay. What about the skin discoloration? That it seems like that happens in most people.
So going back to your question, the side effects, there are expected side effects and obviously unexpected ones. And the common ones that we see are the discoloration of the skin, and that's related to the clofazimine and rifabutin or rifampicin. The clofazimine is the main one that darkens and gives you a suntanned appearance, and that's because it's quite lipophilic, so it distributes in your tissue quite long, and it has a long half-life of 90 days, so that means it does take a long time. Once you stop the medication, it'll take a number of months, if not a year, to get back to normal colour. So it is reversible. I would say we don't know why, but only 70-80% seem to get this discoloration, whereas we don't understand why 20% wouldn't. And the rifabutin, the rifampicin, would typically cause more of a reddish complexion, particularly in the exposure to the sun. So we do say people to wear sun cream or stay out of the sun, wear a hat. Rifabutin, again, reddens all secretions, so you can get red urine. So we say good hydration for that. And avoid contact lenses, because that can your secretions in the eye can be irritated like that. And then the unexpected ones, I would say, of side effects, particularly as we said, liver function tests or liver function discrepancies, and some people can get a mild or anterior uveitis of the eye with the rifabutin, but I haven't seen that, and I particularly haven't seen that with the ramping up dose.
So the liver enzymes that you see, if you do see that, is that a reason to stop the medicine, or is that something where there's adaptation and it may go down just with continued use?
That's right.
Okay.
Yeah, so we just keep it at that level. If say they're on 2 or 3 tablets of rifabutin, I'll often drop it down to 1, and then repeat the blood test a week or so afterwards, and then keep them on that for another couple of weeks, and then increase slowly, 1 tablet at a time. So, and that seems to have worked. If, say, you get a direct reaction each time, and they go in the hundreds, so 400-500, then I would then switch with rifampicin, which they seem to tolerate just fine. So it's interesting. It's not to the family of rifamycins; it's one or the other.
Mm-hmm. And just back to this skin discoloration, a lot of patients with IBD are young, and may have more concerns about cosmetic issues, and many of them are not married and are kind of going through that whole process. Is this something that's like physically very noticeable to the point where there's people walking around looking like they're orange, and or is it not that big a deal for most people?
Well, I say in terms of effects, most people would notice, change in the color. And normally it's not an orange. It's more, like you've had a nice tan, healthy tan. And in fact, some people would like that, particularly youngsters. It can lead to non-compliance, I agree. And it can be in severe people, cases with, lead to depression and anxiety, as we've seen in some cases of leprosy. So it is a significant consideration, but then I would say most people are happy to have that side effect because they've responded to it, and they'd rather be well and have a good quality of life. So it's one of the trade-offs. But there are some new drugs that have been developed in this family that don't seem to have the drug side effects of discoloration, skin discoloration. Okay, and would you say that if someone's already more like dark skinned, either is it noticeable? No, not in them. No. Okay. I just wanted to interrupt here, John. I just want to make sure you're okay with, because I know by now it's like 12:30 where you are. Are you still on the call?
Oh, just back from the party now, so I'm fine.
Oh, okay. John's a night owl. He likes working. Burn the candle at both ends.
So I just wanted to see from you if you're okay with staying on the call, or a lot of the subsequent questions. You're okay?
Yeah, I'm fine.
Okay, good. All right, so feel free to chime in if you have anything to add with any of these questions. Though a lot of the rest of them are more in the clinical realm. But So John and I talk a lot about the clinical side. So he and this is, I would say, just a quick mention of a caveat that specialization has kind of led to a slight regression of involvement in medicine. It's discussing with people from other disciplines and expertise that we can generate our knowledge. So John's been very helpful in terms of treatments and what we can use or what should be expected, because he's understanding the way the antibiotic or the drug affects the organism or the body. And so, one of the ethambutol, does it work? We were talking the other day or at the time, does it work in MAP
given that's an atypical infection, whereas, we use it in TB treatments. So it's a great thing to keep aware, to involve other disciplines, microbiology, infectious diseases, and immunology, not just gastroenterology.
Sure.
I think I just add to that. I think the lab has been very deficient in helping gastroenterology with this issue.
Yeah.
It's been left to the university laboratories, and the people who mostly have anything to do with mycobacteria are present in your local diagnostic laboratory, and that bridge has to be opened between the lab and the clinician.
Mm-hmm. Yeah, and not just the lab and or basic scientists and GI, but also amongst other fields. I think in different scientific fields. I did a podcast. I don't know if you're familiar with Jack Cruz, who's really into even using biophysics in the setting of medicine. So. But yeah, I mean, he said in his interview that he wished there would be more cross-disciplinary, or even gastroenterologists should read outside of their discipline just for like new ideas and a fresh insight on diseases that they may otherwise not be completely comfortable treating or not getting the best results.
100%. And, as you're seeing with the specifics of Mycobacterium itself, a gastroenterologist is not taught any of this in their training. You don't even really have an idea of basic immunology or principles of infectious diseases. So with, like you're saying, utilizing different disciplines gives you a different point of view in how you incorporate it. And in business, they do that, group thinking or brainstorming. Different professions will offer different solutions. So it's an underutilized and neglected tool, I say. But that's the thing with specialization and subspecialization. You become an expert in that particular procedure or field, but you can't look at the whole body as a system.
Mm-hmm.
It's the emperor's new clothes phenomenon, in that there's always somebody who can add the missing link to a puzzle. And that's why I'm so keen on promulgating the idea that there may be an infectious agent involved, and that's what all our work has been doing, because it brings in my network, and my network includes the biochemists and all these other areas that we're not fully utilising on Crohn's disease at the moment.
Mm. Okay, so back to the antibiotics, the treatment. So what about are these safe in pregnancy? What if you have a patient who's on this and then subsequently gets pregnant or is already pregnant?
Yeah. So, and you also mentioned what are the troubles of long-term therapy. Luckily, with these treatments, we have long-term data over decades with TB therapy as well as leprosy treatment, and patients can take these for years without any side effects. So it's such a, I would say, safer approach to Crohn's treatment, which you're not losing anything by it. Pregnancy, yes, the clofaz and the rifabutin can be transferred given its high distribution in the body, and also in breast milk. But it doesn't seem to cause any harm or any troubles from the data in treatments. But we always advise we're a bit, we just be proactive, that we say if you can stop those medications for 3 months beforehand, that would be more helpful.
Okay. But if somebody is already on them and gets pregnant, you just kind of treat through and continue it?
Continue through it, yes. We do ask, are you planning, and when are you planning? If you are, can you just let us know,
Sure.
And then we can work something through. But yes, if they fall pregnant and they're on it, we just say continue. Because as we know, active disease is probably the worst thing.
Mm-hmm. Yeah, in this kind of the standard way we treat IBD just with biologics, even nowadays, the newest recommendations are just to treat through. We used to kind of like hold the biologics a certain amount of weeks prior to delivery, but now they say just treat through, and that's not necessary. So, okay, because of that concern, IBD can get worse during pregnancy, and that would be even worse, and the data seems to suggest those medicines are pretty safe, with the exception of methotrexate in pregnancy, and also Xeljanz now they don't recommend. Okay, so can you go over? So there was this big trial, right, in 2007 called the Selby study. This was this 2-year combination antibiotic therapy with clarithromycin, rifabutin, clofazimine for Crohn's disease. So there they used 3 antibiotics. And there's a lot of controversy regarding this study, but this was this double-blind randomized controlled trial of 213 patients, antibiotics versus placebo, with a 16-week tapering course of steroids. So can you just briefly go over the basic finding of that and why it's such a hot topic as far as it being a controversial finding?
Yeah, so this is really the seminal thing that's used to say lack of efficacy or lack of effect of anti-MAP therapy. So it's 2 years, 213 patients, and they did it as an intention to cure rather an endpoint of intention to treat, which all other Crohn's trials are. So they didn't find any statistically significant role for M. avium paratuberculosis in the pathogenesis based on their response rates. So the reason this has caused a lot of controversy is how the study was done, designed, and reported. So first, as we said, the endpoint was not, I would say, realistic, because we don't know what therapy eradicates MAP. And if you take the analogy to tuberculosis, current success rates of fully sensitive TB is 81%, and the WHO wants a target of 87% cure. And then if you go to resistant TB, so multi-drug resistant, that drops down to 55%, and then severe drug-resistant TB goes down to 35%. So if you see something similar with MAP, we can't say there's an intention to cure with anti-MAP. So the other problems or flaws highlighted afterwards one was the preparation of clofazimine used, which the authors admitted wasn't certain whether delivery was optimized to the bowel, and then the doses of clarithromycin were also suboptimal than normal therapy, which is one of the more important antibiotics as well. So in regards to that, despite that, there was a lot of reanalyses afterwards, particularly by Marcel Baer in the Lancet. And when you applied an intention to treat analysis, it was quite significant. And so 41% at 52 weeks responded, which is better than what we see in Humira and Remicade with the CHARM and ASCENT-1 trial, respectively. So again, it's all about interpretation and how you look at the study. The trial designed by Selby showed that a lot of patients left early, and so it was underpowered as well. So, and there was, they didn't interpret the Crohn's disease activity index scores correctly either. So all these were reanalyzed and looked at, and then there was a statistically significant difference with the Baer reanalyses. So that's really caused a lot of confusion and confliction, and the main reasons gastroenterologists don't want to use it. This is my personal opinion of the limitations of just relying on double-blinded RCTs, particularly investigating a new form of therapy, because you have to understand what you're treating and if you know the meds are treating. So it's quite good for comparison and small signal studies, but where in this case I would say prospective observational trials are more suited, and we're not blinded, so therefore we can see. So but there is the new study that's waiting publication. We don't know what's going on yet, but that's the Red Hill RHB 104 trial.
Okay. I just wanted to go over a few of the critiques of using this as evidence. And you guys are familiar, right, with this Red Journal article or editorial that was written as a response to you guys by Lichtenstein?
One, yeah.
So Lichtenstein and some other authors had responded to the letter, I believe that was written by Dr. Barodi, about the exclusion of MAP as a treatment option in the ACG guidelines for Crohn's. And some of the critiques of using this particular study, even with the reanalysis, was that the CRP and albumin of both patient groups was similar throughout the duration of the study. So I guess they're saying that perhaps the antibiotics may not have been influencing inflammation and just symptoms, although CRP is not the most accurate assessment of inflammation, and neither is albumin. So what do you say to that point? Anything to say? Yeah.
Again, I would say it's a non-specific response.
Right.
You're looking there, and if we're looking, parameters of response, the CDAI was quite suggestive, and yes, they also mentioned are you treating MAP or are you just treating SIBO or
right.
the flora? And probably you are, to be honest, you are corresponding treatment alongside, but again, the antibacterials used are pretty specific for intracellular infections. So particularly clofazimine works on energy mechanisms of Mycobacteria only. So you don't typically use CRP and albumin for other trials for immunosuppressive therapies on its own.
Right.
So.
Right. They did mention that nobody at week 16 had assessment of mucosal healing, and subsequent to that, few patients did. So I guess they're don't like that wasn't a major outcome measure in this either.
And so yes, and using that as a negative, but that's again part of a flawed trial study design. And at the time, also mucosal healing wasn't that much. 2007. Let's not forget it was done, so it wasn't a big critique of outcomes. Now we're looking at deep mucosal healing and subsequent involvement. So that's I think again pretty tough to measure it with.
Yeah, I think that is a little bit unfair, given that some of the biologics we use now also used CDAI as the main outcome measure, and they're still used now. So you can't really use this like revisionist history or looking back and saying, oh, you should have done this, when at the time that really wasn't an outcome measure, even though now it's like required by the FDA. So it's I thought that was a little bit unfair criticism.
Yeah.
So what about this paper, targeted combination antibiotic therapy induces remission in treatment-naive Crohn's disease, a case series which you published in March of 2020 in Microorganisms. And I will link all these studies in the show notes. So if anyone listening wants to actually look at these papers, I'll link them. So can you give us the rationale here of why it was important for you to study anti-MAP antibiotics in patients with Crohn's who have not had any other treatment? So this was the first treatment that they were getting. Yeah.
So the reason it occurred is because these patients came to us seeking this treatment as first line. They didn't want to go on immunosuppressants, and they've done their own research, as the thing is now on the internet, and how medicine is progressing. So, and because we offered it in resistant cases initially, we had the experience, and we wanted to see whether you get a better effect with initial responses. And so this was an important paper for us to show that if you utilize it as first-line therapy, you seemingly appear to get quicker response rates, and also avoiding the need for immunosuppressive medication. So that's how it came about. Although definitely it's a limited number, it's really a proof of concept paper report. So particularly we have submitted a paper for pediatric responses as well. So if this can be used for them, because their treatment options are even more restricted than the adults, it could work really well.
Mm-hmm. So yeah, it looks like you studied 8 patients with rifabutin, clofazimine, clarithromycin, and seems like 5 out of the 8 were also on Cipro and Flagyl. And there was a statistically significant improvement in the Crohn's disease activity index at week 6 and clinical remission in all 8 patients. And all cases had an elevated CRP and an elevated CDAI at enrollment, and 7 patients had a colonoscopy a year later with complete mucosal healing, including normalization of histology. So, okay, yeah, I mean, that was very impressive pictures also of the before and after of what happened. So, although it's not a randomized control trial, it's a case series, technically considered low-quality evidence, but still, it's an intriguing thing and requires further study. But it is a phenomenon we see with pretty much all Crohn's medicines, is that the first treatment you try is often the one that's going to give you the best odds of actually working out. So, and I know in the paper you mentioned that potentially biologics and immunomodulators may lead to MAP resistance and therefore a more difficult to treat infection if they were to have gotten those medicines up front before trying this. So can you elaborate more on that concept?
So and then I'll bring John into that as well. This is reflected on our observations and treatment responses with patients here. So typically some patients of these treatment naives would respond within weeks as such, and often people who've had 2 or 3 biologics, they could take up to 6 months to get response, and that's quite challenging to to persuade them to continue on it for that length of time without a response being seen. But often you do get that. So and John can say the mechanisms of how you're getting the resistance from the biologics, but it's typically due to the MAP in the tissue.
But I think that as a general view, if you accept that we're dealing with a microorganism and not an autoimmune disease, then the story of any microorganism or any infectious disease is that if it's left, it tends to get worse. And Crohn's has its ups and downs, but generally the disease progresses. At the same time, the gastroenterologist or the infectious diseases or the primary clinician is giving different therapies. Now, if any one of those therapies worked to get rid of the bug, then that will be fine. But the history of all these therapies is they work for a while and then they stop. And then you go on to another therapy and that works for a while and then it is no longer effective. So what you're looking at is an organism that is evolving in response to everything that's thrown at it eventually. And we end up with the biologicals, and you'll get antibodies forming to the biologicals, and eventually the biologicals tend not to work. But the patient will get remissions in between. But what's happening with the organism is it is evolving in response to the therapies, and it's learning new tricks. It's getting a better outer coating on it, and it's becoming more resilient to the therapies. So it's a complex thing that's going on, but you can tell that it is evolving because the therapy ceased to work.
Mm-hmm.
Yeah.
Yeah, I mean, it is a scary thought that, potentially these medications, these biologics that we're giving, are they potentially making the disease course, although in the short term controlling things, but over time, are we inducing resistance of this, of MAP, if that in fact is a contributor? I mean, I worry about that. Ultimately, you do have to get things under control initially. Yeah. And even now, pretty much all the new studies on medications for IBD are parsing the population that's enrolled in the study into anti-TNF naive and anti-TNF experienced. And pretty much across the board, anti-TNF naive patients do better with like whatever treatment they're studying.
Yeah.
Some people make the argument, it's just that if they're anti-TNF experienced, that means they probably just had more severe disease and didn't respond to the anti-TNF, and that's why subsequent medicines may not work as well. But I have heard the argument that maybe it's the anti-TNF itself causing some sort of issue, even though in the short term it gives you some relief. but maybe altering overall the course of the disease.
I think, yes, you're right. And we're quite interested in TNF alpha production and its role. Is it a signaling molecule and things? It's some proposal that these biologics drive MAP down deeper into the tissues where it can hide, particularly from antibiotics, or it's difficult to get to reach it to eradicate it, and it becomes embedded in a more chronic resistant pattern. So definitely, and then different forms would probably come about from this treatment course. So it's very concerning. So we don't know the long term what's going to happen there.
I think it's the best argument for personalized medicine. Because the organism evolves in the individual patient. It's not happening across the population. It's a battle that goes on in the individual patient. So therefore, personalized medicine is the best approach.
And that's a hugely important point, I would say. Using the blanket treatment as we do for other infections or diseases is probably not going to be the best. And, we see higher rates of personalized regimes in tuberculosis eradication and therapies rather than a set regime. So I think that's going to be the same for MAP.
Okay. How do you manage patients who have failed anti-MAP therapy as first line? I'm assuming this doesn't work for everybody. There are people where it doesn't work. Correct me if I'm wrong, but if that's the case and you are using it first line, then where does it go? Where does the treatment algorithm go from there?
Well, first line, I would say very few people would fail it, to be honest, in the experience. But if they do, the small numbers, and I'm talking maybe 5% or 10% even, that we do have second, third, fourth line treatments of anti-MAP available, and that's either altering the fourth antibiotic or adding on a fifth antibiotic, and that normally gets them under control. If, say, they came with fistulae or really aggressive disease and we really want to try and get it under control, we would typically add in a biologic alongside. And we did do a paper a while ago for fistulizing Crohn's disease, utilizing combination therapy. So used anti-MAP and anti-TNF and even hyperbaric oxygen. And these, again, end-stage Crohn's, looking at surgery and resections, and they pretty much, all recovered. So that's part of the individualized therapy. But, there's fortunately a lot of antibiotics that we can use to try and target MAP. With the diagnostic side, the big aim and the hope is that we can get drug sensitivities, which I think will come back soon enough.
Okay. And let's go into that study a little bit, this study titled Combining Infliximab, Anti-MAP, and Hyperbaric Oxygen Therapy for Resistant Fistulizing Crohn's Disease, published in November of 2015 in Future Science. And, that looked at 9 consecutive patients, all with fistula refractory to medical therapy, including immunomodulator, infliximab, steroid, flagell, and cetons and drainage. There was rectal, perianal fistula, and also one rectal vaginal fistula, which is notoriously very difficult to treat.
Very difficult.
And you had given infliximab infusions, a mean of 4.4 infusions, and rifabutin, clofazimine, clarithromycin, ethambutol, ciproflagyl were the antibiotics that were utilized, and also hyperbaric oxygen therapy, 18 to 30 daily sessions. And I encourage people to actually look at the study. Pictures are pretty dramatic as far as everything healing up. And in all of these, and these were consecutive patients, right? So it wasn't like,
that's right.
Just cherry picking, it's the ones that actually did well. These were actual 9 consecutive patients you saw. So that was very impressive. I actually have hyperbaric oxygen available in my hospital, which is relatively rare. Most U.S. hospitals don't have it. So I could potentially utilize, and I've been trying to work with the pulmonologist at my hospital. I've been meaning to email them and see if we can set it up as, using it specifically for fistulizing Crohn's, and also potentially for these really these hospitalized patients with ulcerative colitis who are getting steroids as kind of adjunctive therapy. But I know the data is not like that strong right now. I mean, it's still preliminary, but the downside of hyperbaric oxygen is low. The other issue is getting insurance approval, which is a challenge because it's not FDA approved yet. So,
which hospital are you at?
I'm at I practice at a Advocate Lutheran General Hospital in Park Ridge, Illinois. So they do have hyperbaric oxygen there. So, and I think it's one of the only hospitals in Chicago that actually has it. There may be another one, but I think it's mainly used for carbon monoxide poisoning and things like that.
And decompression sickness. So we're really fortunate. We work with a local hospital in Sydney that gives this treatment free for the patients. And the physician there has seen the response and the dramatic improvement in quality of life of these patients, because obviously fistulae, particularly rectovaginal fistulae, can be quite horrendous and quite really impacts on the patient's psyche and relationships and all that. So these 9 consecutive patients were all looking at surgery. And so with the data of using hyperbaric oxygen on wounds, diabetic foot wounds and things like that, we decided to try and incorporate this with combination therapy for aggressive disease and utilizing what we had. And now I would say we are going to be writing an update on this, because we've probably treated about 70, 80 patients. And I would say, again, 80% would be with the healing. Sometimes they need more than one session of hyperbaric oxygen. They may need 2 or 3. But invariably they do respond. And so the rationale is that, as in the paper, it shows that hyperbaric oxygen gives you improved blood supply, healing rates to the wound, but also is detrimental to the colonization of bacteria in the tract. That seems to keep it open, so E. coli and such, as well as direct effects on the MAP bug, which you can be approached from different mechanisms. So, and then
I think if you just on that, because it's an important point, hyperbaric oxygen. One of the ways that it will induce healing is that it forces the organism into a growth phase rather than being in dormancy. The organisms will go into dormancy in anaerobic or hypoxic conditions, but when you're getting a reasonable amount of oxygen there, they will grow. And when they're growing, you have a better chance with the antibiotics as well.
Can you see how priceless it is for us to have a microbiologist who understands all this and can help direct us?
Yeah, absolutely.
As an adjunct, there was in the past couple of years, there was a couple of hyperbaric. I think one was an internal medical physician in the US who did the treatment for their Crohn's patients, and the 2 patients both had success in their response and were presented at their local meetings. So we do work and help people overseas, and they can also help you, given that they've got some limited experience now. And indeed, I believe our physician who does the hyperbaric oxygen will be open to helping and assisting if this is something you want to go down. So we can put you in touch with him.
So for these fistulizing patients, because I saw in the paper it said there was 18 to 30 daily sessions, but are you saying that they only need a few? Most of the patients only need a few sessions?
No, so they'd have maybe 2 or 3 courses of that 18 daily sessions.
Got it.
Yeah. So because it builds up over time and you're trying to improve the vascularity, it takes a bit of time. So they only sit in the chamber for 1 or 2 hours. I think it's 1 hour at 2.4 atmospheres of oxygen. Yeah. And basically just take a book and they read. The one at the hospital, Prince of Wales Hospital, it's massive. You have a TV and you can walk around and there's bathrooms. So it's but some centres, obviously, it's a lot smaller.
So, it remains to be seen if this approach would work out in like a larger trial, and I'm sure you guys are working on that. But this is the problem with, because I appreciate this approach of like almost throwing the kitchen sink at these fistulas because they are very resistant to treatment. the the response to biologics is not perfect, especially long term. So, and the issue with what you guys are doing, it's going to be very difficult to do a randomized controlled trial on something where you're combining all these antibiotics and infliximab, and for that reason, it probably will never be done, and it probably will never be widely adopted, at least in this country, because there's so much emphasis on the RCT and the meta-analyses to guide writing guidelines, and so that type of research is not conducive to these multimodal approaches because people can't get the funding to actually study that kind of approach in a high quality way.
It's a huge problem. John will definitely, I hope, will contribute. Is that this is the fallacy of modern medicine, how it's approached is the reliance on statistical analyses and rather than observation, which was the main method since Francis Bacon introduced the scientific method. So, how are you going to do a randomized control study in this? It's almost impossible, to be honest. Mm-hmm. But that shouldn't negate the physician of trying to treat the patient, I think, with logic and scientific observation. It's changed lives, and that's what we're ultimately trying to do in a safe and effective manner. These treatments won't give you cancers or lymphomas and MS and stuff, which we know can happen with biologics on their own, but hyperbaric and anti-MAP are fairly harmless. And if you get that signal where the prospective observation trials, then that should suffice in terms of evidence. But again, what really is a broader question is what have we cured in the last 30 years since Helicobacter and peptic ulcer disease with the implementation of these type of evidence-based medicine? I'm struggling to think of one, really. They're all being done by fortune and, persistence.
Mm-hmm. And I think that's a very good point. I was sitting here before thinking it's a bit like the triple therapy, for instance, is a bit like the discovery of gunpowder. Everybody knows that it went bang, but nobody knew exactly what the process was for it to happen. And then you led on to gelignite and dynamite and all these other things. And it's left a little further down the track for the scientific side to say, that's how it works. It does this and it does that, and these things all work together. So you can avoid a randomized trial by explaining how these things work. And if that is logical, then it should answer the question. And behind it all is the whole question of what causes Crohn's disease. If you can sort out that there is definitely a mycobacterial cause for Crohn's disease, then everything else becomes almost redundant.
Gets changed.
And it becomes logical then. Mm-hmm. It's just that we everybody put the cart before the horse, but the horse is actually causality. And I think we're well on the way to answering that question.
Mm-hmm. Yeah, I think, as just the last point on this is that with the introduction of statistics and epidemiology from Bradford Hill in the, I think, 60s, 70s, that, even he foresaw that it could be overused and for different purposes. I know in the States, pharmaceuticals have a massive role and they want to show efficacy of their drugs or comparative, so they do non-inferiority studies now. But does that really contribute to the development of medicine? I'm not so sure.
Mm-hmm. Yeah, you mentioned, the one thing that comes to mind for me as far as something that we've cured is hepatitis C, I guess, is one example that the standard kind of pharmaceutical approach has cured that. But you're right. Besides that, I can't really think of anything else. Okay, so can we go over the just very briefly this RHB 104 phase 3 randomized controlled trial? So what's different about this trial and what are the preliminary findings?
So it's quite an interesting study. Again, it's actually in a combination pill, and although they haven't published yet, they presented at I think it was UEGW as an abstract. They showed similar results to biologic therapies with some dropouts, but they utilized steroids alongside their initial responses. But they found a statistically significant benefit in patients with the anti-MAP arm compared to placebo. So I don't know why it hasn't been published. It's been 2 years since it's been finished, so I'm sure there's some reasons there. But there was a subgroup utilizing, that's, as I was saying previously before, with infliximab that showed even better responses. So it could be a very useful study. I think the trouble is the FDA and critiques of the MAP, of the trials, that they obviously haven't had MAP proven, and what are you treating again, and are you seeing a treatment effect on MAP or generalized? And so I think they're planning for future studies with diagnostics, but whether that's going to be PCR, I don't know if that's going to be helpful or not.
Okay. Well, FDA seems to be signaling if you're using these therapies, what are you actually treating in terms of the organisms? And so they're just asking for the animal models and the causality evidence as well, which is quite sensible and I think is attainable now.
Okay.
Yeah.
Okay, so we can look forward to those results hopefully coming out. So, and one of the worries I have about using antibiotics long term is that we know antibiotics are a risk factor for the development of IBD, and also amplify microbial dysbiosis that actually correlates with worse disease activity in Crohn's. And specifically, I'm citing, there's a study looking at the title of the study is The Treatment-Naive Microbiome in New Onset Crohn's Disease, published in 2004 in Cell Host Microbiome. They go over this issue where antibiotic exposure is associated with this specific signature, this microbial dysbiosis that correlates with increased disease activity. So I understand that it's a different scenario once you already have the disease, and then getting antibiotics that are hopefully more of a targeted approach. But is this something you worry about, of being like long-term antibiotic use in patients, when we know there are many health conditions that are at least correlate with dysbiosis?
Yes, that is probably the case. I'm not so concerned, I have to say, because we're not using antibiotics like amoxicillin, or cephalosporins that have a much more impactful effect on the microbiome, particularly gram-positives, as we know. And so what we see with the changes in microbial diversity, it goes from a gram-negative to a gram-negative component and deficiencies of certain species. The anti-MAP antibiotics, we were saying, are predominantly intracellular acting. If you use something like metronidazole, then perhaps that targets it, but then that does target E. coli and some other detrimental species. So I don't know, to be honest, how much of an impact on the microbiome it will have. But with coming off treatment with a fecal transplant, you're going to be restoring that diversity. So really, we need to see, is it the chicken or the egg? Does the dysbiosis allow MAP to cause disease? Or is MAP causing the dysbiosis of the microbiome? Because that will have important implications.
Okay. And how do you make this decision as far as who gets fecal transplant after a course of antibiotics or not? Is that like an ongoing clinical trial?
Yeah, that's right. And therapy, because we, as you say, and what we've observed is that most relapse off the antibiotics, months or years or not. The only long-term remissions are the ones really who've had FMT afterwards. There was only one patient in that study that just had antibiotics and seemingly cured himself, or long-term remission, but all the others needed FMT, and that was noticed particularly with if they had C. diff infections. So somehow correcting that dysbiosis prevented relapse of the disease. And now with modern techniques of microbial signatures and detections, we can now get a quantitative analysis on that and better data, rather than just saying FMT works, but why is it working? What's it targeting? What's it replacing?
Okay. But you do have would you say most of the patients nowadays that you're treating for Crohn's are strictly an antibiotic approach? If they respond, they pretty much just stay on the antibiotics, or is it more often that you're trying to get them to get the FMT after a certain duration of antibiotics?
Yes, we do talk to them about the possibilities. Obviously, the long-term use of antibiotics is not what many would want, but they do recognize that need because, they've been presented that Crohn's is incurable and they need lifelong immunosuppression or such like that. So we often say you can trial with FMT after 2 years and see how you go. And if you relapse, then you can go back on the antibiotics. And often they would respond again. The great thing about the antibiotics is that I've maybe seen a handful of people who've relapsed or you had the detrimental effect on the antibiotics. Pretty much everyone, if they take the medication, the compliance, they remain well.
Okay. And do you have any comments on dietary therapies? Are you having patients come to you who are already on one of these diets, like the specific carbohydrate diet, whole food plant-based diet, IBD-A diet? There's a lot of them out there. And how does that fit into your recommendations, pre-treatment, post-treatment? How do you discuss it?
Well, we do have a dietitian at our practice, and so, we'll get them to see the patients as well and work up with, more healthy components, green vegetables and lettuce and all that, and try and avoid sugars and, red meat and dairy products. I think it's a very underutilized therapy, and, John and I have been talking about this, that it's going to be a big therapy to use alongside and something we're trying to develop more. The patients I've seen, they tried pretty much everything or been on everything. One patient seemingly induced his remission just having to have a glass of oregano juice every morning and didn't need anything else, and he had complete remission. So, I know it's only n equals 1, but still it's showing that these effects are present, and hopefully we can get better consistency. So maybe John might like to mention something there.
Yeah, I'm really interested in it because we can mimic in the test tube the introduction of compounds present in the bowel that are not produced by the human, so they're produced by bacteria, and put them into a test tube and see if they promote growth or to see if they inhibit growth. And we know that those compounds, cysteine, tryptophan, all those sorts of things are regulated in the body. So the question is, if you put them into bacteria, what do they do? And then when you talk to patients about it, the only patients that are really available to talk to are the ones who are having problems. The ones who have managed to get into remission by diet don't actually want to talk about it. They're quite happy. They've gone off to the beach and they've gone to other places. And we don't gather data on those successful patients who have controlled themselves by diet. So we're not able to take that diet and back engineer it to the Crohn's disease patient and see what is there and what is missing. So I'd really like to see a lot more studies done on diet, particularly those individuals who have got themselves into remission and who know in their heart of hearts that something that they are taking is maintaining that remission, but they don't want to discuss it with the clinician because they may think that the clinician will ridicule them. Mm-hmm. And we don't know any of that.
That's a big problem, I think, because we don't understand how it works, we kind of do dismiss it quite easily, and yet these are, you apply alternative treatments, but it does work for quite a few people, to be honest. So what's there? Maybe we can understand it a bit better.
Mm-hmm. I mean, are there certain dietary components that you know of that would necessarily, besides particularly having MAP in them, like beef or dairy, but like, for example, like a hypercarbohydrate diet or fat, or it's like kind of like the macros of a diet? Are there specific components that lead to more virulence of MAP, or do we not really know that yet?
I can say with some certainty that it's a good idea to keep the cholesterol low in the Crohn's patient, and there have been studies done on that with the patients on statins tend to have less flare-ups, and intriguingly, when patients develop a flare-up, their cholesterol has been observed to drop. So it tends to suggest that cholesterol in itself may well be a compound that is utilised by MAP, and in fact, one of the best pathways in the organism is the utilisation of cholesterol and the conversion of it to mycolic acid lipids. So cholesterol is something that I would really like to see more work done on in terms of using it as a surrogate marker for patient progress. There's a lot of work needs to be done on that, I think.
So, do you mean dietary cholesterol or cholesterol?
HDLs and cholesterol in the bloodstream, but obviously you're taking that in as a dietary additive. But certainly there is. If you go back and have a look through the literature, there was a time of heady optimism in about 2015 when it was discovered that the use of statins did correlate with less flare-ups, and that then went on to other studies on cholesterol, and I would say that on the laboratory bench, it certainly raised my suspicions about cholesterol levels in Crohn's patients, flare-up versus remission.
Okay. Yeah, I mean, dietary-wise, what would, nowadays they say that, dietary cholesterol doesn't have much of an influence on the actual lipids in the blood, more saturated fat. So maybe that would be something to limit, and there are certain diets that do specify that, to limit saturated fats in the diet.
I think it's not so much the predilection of the host to the cholesterol, it's the predilection of the organism to the cholesterol and what metabolites it may produce.
Okay. So, just to go over that, a couple other of the criticisms from your skeptics, this letter that was written by Lichtenstein and colleagues, they let me look here. Yeah, they had a couple other points I just want to get your comments about. So they said that antimicrobacterial therapy has not been shown to be effective for the induction or maintenance of remission or mucosal healing in Crohn's patients with Crohn's disease and should not be used as a primary therapy. This was actually, not in the letter, but this is the statement in the ACG guidelines. So they definitively say that it should not be used. They also say anti-MAP therapy also has not been recommended or mentioned in the ECHO guidelines or by the Gastroenterology Society of Australia, British Society of Gastroenterology, Taiwanese Society of Gastroenterology, and Japanese Society of Gastroenterology. So how do you feel about those statements? I mean, I think I can pretty much gauge what you're going to say based on our whole discussion today, but that just so the audience knows, that's what's I mean, the audience has now heard most of the relevant studies here, what you guys have said, and they can be the judge. But ultimately, this is what the ACG guidelines say about Crohn's. So if you're seeing a GI physician, an IBD physician in the U.S., it's most likely that their practice is going to be in line with these guidelines, and this is what they're saying.
I would say yes. You kind of follow and get security when you have large institutions saying the same thing, and Einstein always says, like, blind authority is the enemy of truth, really. So there is studies, I mean, unfortunately not RCTs, which is their main requirements for proof of efficacy. Often they're open label trials, case series. There was an open label by GUI in 97 of 52 patients. You got clinical remission in 46 out of 52 patients, so that's 88% or so, and that was at 24 months. So, and in that, 90% came off the steroids, were able to wean off the steroids. So there is quite good evidence in it. But then again, I got to say, do we have the right treatment completely to be able to say that? And as you're saying, hepatitis C has been cured with the right antivirals, 98, 99%. But if you didn't have those antivirals and know what they are, you're not going to get high success rates. So I know they are guidelines in the end, but it's very difficult to change mindsets. And the big thing for us, obviously, and for everyone, is the diagnostic, not observing MAP reliably. So I can understand why they've gone down that route. But you're not progressing medicine, I feel, by just doing the same thing.
Sure.
I think I'd add to what Gorev said, which is very good. That statement is really a challenge thrown out to researchers to say, prove us wrong, and I think that's perfectly understandable. That in the modern day, people do require concrete proof to refute whatever it is they believe. And that's the role of the researchers. And I think that it's becoming more and more evident that new ways of doing this are required. And also, I think, in fairness to the researchers, because it is assumed that Crohn's disease is an autoimmune disease, there has been very little funding put into the infectious side of things. And I think we're now at a tipping point in which new evidence will induce people to look more seriously at the infectious disease side of things. I believe this is an emerging infectious disease. And like all emerging infectious diseases, it takes a while for it to be completely understood.
And our dad, Professor Brody, who's a close colleague, lived through the Helicobacter era, and how all these societies was, again, against Helicobacter causing peptic disease, and dismissed it, really. So, unless we can prove it and show it, it'll just continue like this.
Yeah, the gauntlet's down.
Gauntlet's down.
Yeah.
I'm not a conspiracy theorist, but people have reached out to me to ask this question. The pharmaceutical industry, obviously there's multiple companies putting a lot of money into drug development and also have existing drugs that fit into this paradigm of IBD being mostly a disease of immune dysregulation without a specific pathogen being at the center of it. So there is this there's a lot of money behind defending that paradigm. So is that influence, because these guidelines, to be honest, most of the authors most of the IBD experts in this country and worldwide are on the boards of these pharmaceutical companies. They advise them on how to do research, and oftentimes a lot of the top people are on the boards of like most of these companies. I'm not casting any aspersions or saying that influences the way they treat patients or what they do or if they're influenced by it. But it is a problem that's not brought up by me, but it's been published in editorials that guidelines, people question that should guidelines be written by people who have this conflict of interest there, and it's stated in the guidelines. You can see all the authors and that doesn't just go for IBD. It goes, medicine, like everything. All fields of medicine. It's the world experts tend to be on the boards of these companies. Is that influencing things? Is that influencing the resistance to adopting or acknowledging there may be something to your theory, or at least putting more money into it? Now, I also acknowledge that perhaps, I don't know this for sure, you can let me know if I'm wrong, but there may be a conflict of interest on your side as well, as far as, I know you guys, I'm not sure if you guys in particular, but this drug that's being this combination pill with the antibiotics in it, all combined in a pill, is being studied now, and I believe that there is some financial interest in that being successful as well. So it kind of goes all around. Yeah. But yeah, just your general comments on that issue.
Really interesting, and it's important, and it's good that you noticed that. I think I read the editorials on that as well. This again, it's the trouble of modern medicine. Like, who's going to be able to develop drugs? If we go first to the pharmaceuticals, who's going to develop them, and what are they going to get out of it? So big trials, they cost $3-5 million at least to do these RCTs, and governments and hospitals aren't really doing them nowadays, if at all. And if you do, you're going to need grants, and you're going to need charitable donations possibly, but they're all along the same lines of the same type of research. So there may be like this thing that we believe how it is, so we're just going to continue. You get taught this manner by your peers, and they pass on those same ideas and beliefs to you. So there's not that innovation to change and study different possible causes. The conflicting interests is, yes, like you said, it's everywhere in medicine. It's not just gastroenterologists. They're experts, so they get employed, and they're involved in development of drugs, and recruiting patients for trials. And the main things that we're seeing is that instead of the physician getting the percentage, that research departments are getting better funded from companies, so you don't have to, it's not like a personal declaration or conflict. It's really, really difficult. How are you going to progress? Who's going to put the money in otherwise if they don't get a profit? For us, I mean, I know John's going to say John has some interest with the diagnostic side. Myself, I don't really have any interest or conflicting interest, but my colleague where I work at the centre does, and he has a number of patents to develop. But the RHB 104 trial, obviously Red Hill are promoting, and they have a invested interest in this. So I don't have an answer to that really, but I think personally people should be free of conflicts to write guidelines or advice, because there's always a possible subconscious even benefit, and in the end those who miss out or lose out on a change of a paradigm are the ones most resistant to it. John, do you want to say anything there?
I don't have any conflicts per se. No. In fact, what I've discovered is that the research into Crohn's disease is a very, very good way of slowly eating into your retirement funds and and searching for an anonymous benefactor. But the first thing is that just to sum up the idea of the conspiracy theories, I think it's very simple. It's really a case of human nature. It's an old saying that it's very difficult for an expert to prove themselves wrong, and I think that applies in these sorts of situations. The other one is that everything is run in a commercial and a competitive nature. So it's perfectly fine for pharmaceutical companies to manufacture therapies which are accepted by the majority of the profession. Should, however, convincing evidence to the contrary come up, then it becomes unethical for that approach to continue. And it goes right back to the discovery of penicillin and pneumococcal pneumonia. Prior to the discovery of penicillin, there were a number of ways of treating pneumococcal pneumonia. When penicillin came in, there was really only one. So science will take care of everything. I'm quite certain of it. There's a point at which it's no longer ethical to proceed along a certain path, and this is what happened with gastric ulcers. It was no longer ethical to cut large chunks out of an ulcerated stomach when you had triple therapy.
Yeah, and just personally, I also don't have any conflicts of interest. But I recently actually looked at, there's this website called Dollars for Docs, and I just, by chance, I searched my name to see, and it said that I received something like $40,000 in 2017 or 2018, something like that. And I was very confused, like where I didn't get any kind of check like that from anybody. And I realized that... I realized the reason that was there is because I did an IBD fellowship at that time, and I didn't even know this, but that salary was funded by Pfizer. And I didn't even know that. And I actually inquired, and I was told that I don't even have to disclose that as a conflict of interest because I wasn't even aware that they were the ones that were funding that. But and then there is like another $20 thing, which I guess I went to a pharmaceutical presentation, and because I follow a relatively strict diet, I didn't even eat the food there, and then they said I did. So those numbers are not even sometimes not accurate. So don't believe everything you see online. Okay, so we're now almost 2.5 hours in. Sorry to take so much of your time, but I just want to close with probably the most popular question I received is people want to know about this vaccine, the MAP vaccine from John Herman Taylor's lab. They want to know about the realistic timeline for this because this has been on the internet and people have been aware of this for years, like probably for over a decade now, and there's been hope through the years that this would come out. So do you guys have any insights of what the progress is?
I have none.
I mean, this is what I'm currently working on at the moment in London in this trial. So, but really, as we know, the COVID pandemic has really put a spanner in the works of all research and trials and such. So at the moment, it's all stopped, and we're unsure of when it's going to start. We'd hope in the next couple of months, 3 months, but anyone's guess is as good as mine. That, it's quite a remarkable piece of, investigation, you could say. And it's what the COVID vaccine developed by Oxford is based on, the same technology. And so they made this vaccine as well, the MAP vaccine. It's going to require an element of luck to work first time and make, have you got the right targets, the right genes? But, it's interesting how investigation into a new avenue brings up so many other avenues and possibilities. It just develops everything. So, virally vectored vaccine is this type of technology that's aimed to treat as well as prevent the infection of the bug. And that's by utilizing your T cells with an inactivated virus component. I guess the easiest thing to say is just watch this space. But we've got some promising data in cattle where Johne's disease is very notoriously difficult to treat and resolve, and the vaccine seems to have worked in them. Whether that's applicable and transferable to humans, it's unclear, but this is a safety study first and predominantly. So first we'll just see if they can tolerate it, and then we'll proceed with that. So the trial, should, I think, it will last about a year once it gets going.
Okay. So are you saying that these cases of Johne's disease where it was effective, like how effective? Are we saying like partially effective, or is this like completely treating the disease and making it go away?
So in Johne's, it eradicated MAP shedding in all 5 cattle, all 5 animals, which has not been seen, and they all started gaining weight. I think it was 4 out of 5 had tissue and splenic tissue negative after administration. One still had it in the lymph nodes, but it resolved symptoms completely.
Okay. And so do you foresee, like, if this ends up being effective, how do you foresee this being implemented? Is this let's say someone has Crohn's, is this something that could be treatment by itself, or do you foresee people requiring the anti-MAP, the fecal transplant, and potentially getting a vaccine during that to prevent recurrence so that they don't need to take the antibiotics? Like, how does that fit in the current treatment paradigm?
Yeah, really good question. Difficult to answer, I'd say, at this stage, but I suspect, as with everything with intracellular infections, combination therapy is going to be needed. Whether use anti-MAP and dietary interventions and other treatments to get rid of active forms or pathogenic forms of MAP, and then the vaccine may help alongside that. And will it prevent? Or the trouble is, and the difficulty is, trying to get rid of these persistent forms so you don't get the relapse. And that's the unique quality for MAP and why it's so difficult to treat and cure, is they're just such cleverly adapted organisms to reside in our bodies. So will a vaccine be able to eradicate cell wall deficient forms? I don't know. And there's other factors as we think, maybe, like, will biofilm hinder the effects of the vaccine? And as I was saying, there's 4 genes in the vaccine. Have we got the right ones? But I suspect that it'll be combination, and then down the track, the vaccine will improve further in its targets once we have better understanding of the organisms and ability to find unique factors. And then, say we get effective vaccine, it'll be part of the, I'm sure, as the childhood immunization schedules. That's how I see it going.
Yeah, I really appreciate that work you're doing, because there seems to be, I always think the best way to attack Crohn's is preventing it. That's going to be probably the most cost-effective way, and I think enough money has been put into treating it and coming up with treatments. I mean, still, obviously, there's more work to do in that area, a lot more work.
Yes.
But if we can prevent it up front, that would be the best and highest yield way to do it. And if you develop a vaccine, I think that's worthy of Nobel Prize to prevent this from happening to people.
Professor Herman-Taylor would definitely deserve it, given he spent 30 years on it. That's the most, I think, remarkable thing I found, that he's found technologies before their time. That's, for a retired surgeon, that's pretty remarkable. Mm-hmm. And, fortunately, we have a good group, and with John's test, I'm sure we're going to get much better diagnostics and testing and the ability to understand it. Observation and understanding is the key tenet, really, for everything. So that'll open up all these avenues. And there's other things available as well, such as phage therapy and other things. So it's gaining a snowball of its own accord.
And are you guys still accepting private donations for that vaccine research? I remember seeing that online.
Yes, very much so, and that would really help, because we have a number of people that benefit in terms of the research going on. That can be done at crohnsmapvaccine.com. So that'll give you information about MAP and the vaccine, and results will be posted. There's a Facebook group and things, and you can interact, and you can find treating physicians in the world for MAP alongside that. And donations are much appreciated. They're very critical, because there's only 2 roles of funding trials and research in medicine nowadays. One's pharmaceuticals and one's charitable donations. So we'd like to keep that going. So thanks for that. Yeah,
so I encourage everyone, especially people with IBD. I mean, if you're looking for some place to donate, I think this is if you buy into the theory and think there is something to it, and are interested in preventing what happened to you from happening to other people. This is a possibility and something that you may want to consider putting some money towards. And I think the more money that they have available, the faster, because everyone wants to know, when is this coming out? Well, put your money where your mouth is. Let's get it funded so they can let's see if it works or not, and they need money to figure that out. So I encourage you to go to the website that was mentioned and donate if you can. All right, so that's all I got for you guys. We covered a huge, vast amount of questions and ground, and I think that's clarified a lot of things for me and for a lot of the people who wanted me to interview you. So do you guys have any other final words for people, how they can find information about you guys, or if they want to reach out to you, or if that's even something that that you want to happen?
Yeah, we have a website, Otakaro Pathways. That's OTAKARO, Otakaro Pathways, all one word, .co.nz, and I'm contactable through that. If anybody wants to send us samples or discuss what we're doing in more detail. We've got a couple of publications coming out in the very near future that will probably add to the debate.
Yeah.
Okay.
My side, it's been really nice talking and doing this information session. It helps us greatly because it clarifies and organises our thinking and forces us to remember the details and know what we're talking about. So it's been a very, very nice invitation. So thank you for that. In terms of contacting and further things, so predominantly for me personally, I'm been associated with the Centre of Digestive Diseases in Sydney, and they have a website, www.cdd.com.au. I don't think they're taking overseas patients at the moment, but we're looking into that to try and get that back up and running. We would want someone as a treating doctor, physician, family doctor, alongside a patient who's seeking treatment or information. And that's just for safety and to make sure someone's there observing, and that we can also educate and maybe, show them that there's other possibilities in treatment sides. But otherwise, my main role at the moment is this vaccine trial. So I'm residing in London. So any physicians or doctors that want to get some help or assistance, you can just email me or go through the crohnsmapvaccine.com, and my details should be around there somewhere.
Okay, great. Thank you for all your time, and expect a lot of interest. You're going to get probably a lot of messages after this comes out. So and hopefully donations.
Very much.
Sure.
Thanks very much for the opportunity. That's great.
Yeah, it's been great.
No problem. All right. Thank you.